Hi, my name is Jenna Koss, and this is my presentation on gout. JH is a 47-year-old white male whose chief complaint is, I woke up in the middle of the night last evening and my right big toe felt as if it was on fire. It's hot, swollen, and so tender that even the weight of a blanket on it is nearly intolerable. There's no way that I can put a shoe on. His symptoms include tender, hot, feels like it's on fire, unable to bear weight on right foot, right great toe swelling. The patient is presenting to the clinic with severe pain in his right toe. The pain began last evening after his 47th birthday celebration and kept him awake much of the night. He has been taking extra strength acetaminophen to keep the pain under control. He states that he is unable to bear any weight on his right foot. He came into the clinic wearing open-toed sandals and denies any history of injury to his right foot. There are no known childhood past medical history at this time. Adult medical history includes hypercholesteremia, diagnosed 9 years ago, hypertension, diagnosed 9 years ago, TIA 3 months ago with no residual neurologic deficits, and chronic sinus drainage rhinosinusitis. No known surgical history, no recent accidents and injuries or transfusions reported. The patient has no known allergies at this time. Current medications include hydrochloroside, 25 milligrams, aspirin, 325 milligrams, atorvastatin, 10 milligrams, flunizolide, 2 sprays in each nostril, and acetaminophen, 60 milligrams. JH is a 47-year-old white male who is overweight with a BMI of 29.7. He is a non-smoker, but drinks 5 to 6 alcoholic beverages per week on average. He states his current diet is heavy on red meat and other high purine foods. It is unknown if he exercises, but based on his profession, a truck driver, he is on the road a lot and likely lives a sedentary lifestyle. JH's father died at 68 from osteosarcoma. Most osteosarcomas are not related to an inherited genetic mutation, but if osteosarcoma is suspected, then it should be ruled out if there is a genetic link. His mother is alive and has been diagnosed with type 2 diabetes. Diabetes is known to run in families and therefore a possible risk factor for this patient. JH is an only child and he has 4 healthy adult children. No other family history and no known genetic factors related to gout have been reported at this time. High school is the highest level of formal education JH has obtained. He has been employed for the last 17 years as a truck driver and is frequently away on the road. He has been married twice with 4 adult children, only from his first marriage. He lives with his wife of 22 years and reports that he is happily married. His spiritual history and cultural background have not been reported at this time. For the review of system, JH denies any headache, dizziness, chest pain, shortness of breath, and generalized swelling or tenderness of the joints. He reports that he has gained approximately 15 pounds in the last year. He also reports no previous episodes of joint pain. Additional history and review of system questions that I would ask that was not in the case study would include food and beverage intake. He had a birthday party yesterday. I would want to know what type of food did he eat, what type of food did he eat all day, What type of drinks did he have? Did he have alcohol? How many drinks did he have? What type of alcohol does he typically drink? I would also want to know if there's been any recent changes to his medications or vitamins and supplements. When did he start taking the aspirin? My guess is that he probably started taking the aspirin when he had a TIA, but it is unclear at this time. I also would want to know, does he have a cardiologist? Did he have a neurologist appointment after his TIA? Any family history of gout? Any personal history of arthritis? Any personal history of blood clots or any recent illness or operations? Some operations can be, in the OR or same day, so kind of clarify that, or small or big. Complete the missing cold spot for pain. So he is saying that he has tenderness, so I would want to know, how the character of the pain. Is there any smell or odor from the foot? Can he describe the pain? Location? Can he point to where the pain is? Does the pain radiate? Duration? Is it constant or intermittent? Did you notice any redness or rash on your big toe before yesterday? Severity from 0 to 10. Pattern, what makes it better? What makes it worse? Have you tried to improve symptoms and did it work? Also, he says that he is taking extra strength acetaminophen, so I would want to know how much is he taking and how often, and also does it help his symptoms? Associated factors, are there any other symptoms that I would need to know about? Does it itch? Did you recently buy any new shoes? Would you have potentially fallen last night at all? JH is presenting in mild acute distress. His vitals include an elevated blood pressure of 145/85, pulse of 92, respiration 17, elevated temp of 100.2, weight of 225 pounds, and height of 6'1". The patient has a history of hypertension and is possibly presenting with one reading as stage 2 hypertension. The elevated blood pressure could also be connected to pain and white coat syndrome. It will be important to have JH continue to monitor and record his blood pressure at home once his pain subsides, then determine if he has progressed to stage 2 hypertension. The goal is to meet the targeted range of below 130/80. Medication adjustments may be needed in order to reach this goal. The patient's elevated temperature could be indicating immune or inflammatory response. Overall, this patient had a normal physical examination. There was one abnormal finding in his musculoskeletal. His right first metatarsophalangeal joint was hot, tender, erythematous, and swollen. But his pulses were full throughout, and his muscle strength was 5 out of 5 throughout. JH has a fasting glucose that is elevated at 120, a BMI of 29.7 with a 15-pound weight gain in the last year, and a family history of type 2 diabetes. All of these indicate a need for further blood work regarding his HbA1c level to determine if he could be developing diabetes. The HbA1c shows what the average blood glucose level has been over the past 2 to 3 months. Normal levels are below 5.7. Prediabetes is 5.7 to 6.4, and diabetes is 6.5 and above. The patient has elevated uric acid level of 13.1, indicating hyperuricemia and the possibility of gout. JH also has an elevated white blood count, neutrophils, ESR rate, and low lymphocytes, indicating an inflammatory response. All other blood laboratory levels were normal. JH does have an elevated 24-hour urinary uric acid level of 985, indicating high levels of uric acid in the urine and possibility of gout. X-ray of right great toe showed moderate soft tissue edema, normal joint space, no erosions or sclerosis. In early stages of gout, soft tissue edema is often the only finding during an X-ray. Synovial fluid examination showed significant PMN infiltration and MSU crystals confirmed microscopically with polarized light. A definite diagnosis is only made with aspiration and examination of the synovial fluid. The findings are consistent with a diagnosis of gout. Differential diagnosis for this patient could include gout, cellulitis, acute joint trauma, pseudogout, blood clot, and osteosarcoma. Gout is a metabolic disease that affects an estimated 8.3 million adults, where 70% of the patients are male between the ages of 40 to 50. It is also typically found in the United States, Pacific Islands, and countries with abundant lifestyles. It's rarely found in children, premenopausal females, or males younger than 30 years old. We do see an increase in older adults on diuretics. Gout is closely linked to purine metabolism and kidney function. Purine synthesis converts purine nucleotides into uric acid, a waste product that is filtered out in the blood and excreted through urine. An inflammatory response is triggered due to hyperuricemia, which is elevated serum uric acid concentrations in the plasma and other body fluids. If the uric acid levels are elevated over 6.8, the uric acid can clump together and form insoluble precipitates called monosodium urate crystals. These MSU crystals are deposited and accumulate in joints, soft tissue, cartilage triggering acute or chronic painful inflammation. This process causes the release of chemokines and interleukins, which activates the body's natural immune and inflammation response. Repeated gouty attacks cause chronic inflammation and possible development of trophy, which are uric deposits, leading to gouty arthritis, joint degeneration, and kidney stones. There are both primary and secondary risk factors that cause gout. Primary risk factors include genetic predisposition, age, rare before the age of 30, defects of purine metabolism, decreased renal clearance of uric acid, and specific enzymatic defects. Secondary risk factors include diet, purine-rich foods like organ meats, seafood, red meat, drinks high in fructose corn syrup, alcohol, especially beer, medications like thiazide, diuretics, and other medications, chemotherapy or radiation, cytotoxic drugs, starvation, dehydration, lead poisoning, and medical conditions. A couple examples include diabetes, renal disease, hypothyroidism. During a gouty attack, the clinical presentation includes pain, tenderness, erythema, and swelling of the affected joint or multiple joints, most commonly in the first metatarsophalangeal joint of the great toe. The attacks often occur at night, waking up the patient in excruciating, throbbing, crushing, or pulsating pain. There are 4 stages of gout. Stage 1, asymptomatic, where only tiny deposits of uric acid happen in the joints. Stage 2, acute phase or inflammatory phase, where the patient can present with one or more joints affected. Stage 3 is the intercritical phase, where the patient is often asymptomatic and the uric acid levels remain less than 6. The 4th and final stage is the chronic tophaceous phase, where the patient will develop gouty arthritis and joint degeneration will begin. The goal of care for this patient is a combination of pharmacological and non-pharmacological treatments, health promotion and disease prevention, and patient education. I would focus on adjusting his current medications, adding new medications to treat his gouty attack, order additional blood work, and provide education to him on gout, non-pharmacological treatments, and the new medications prescribed. It will also be important to come up with a treatment plan that is cost-effective and agreeable by the patient. This patient is currently on a hydrochloride 25 milligrams. This is a thiazide diuretic. Thiazide diuretics are considered a risk factor for the development of gout, as it decreases urate excretion by increasing urate reabsorption, diuretic-induced hyperuricemia. To prevent recurring episodes of a gouty attack, it will be important to change this patient's hypertensive medication. First-line hypertensive medication, angiotensin converting enzyme inhibitors, ACE inhibitors, and angiotensin II receptor blockers, ARBs, can help decrease the diuretic-induced elevated urate levels. ARB medications are great for patients that have been diagnosed with hypertension and gout and diabetes. Even though the patient is not currently diagnosed as a diabetic, he is at risk for developing it and could benefit from this medication. Losartan or Cozar, an ARB that has more a direct effect on inhibiting urate absorption and lowering serum urate levels than ACE inhibitors. I would instruct this patient to stop taking the hydrochloride and start taking losartan 25 milligrams daily. I would reevaluate the patient in 2 weeks to ensure he is in the target range for blood pressure. If he was not, then I would increase the losartan to 50 milligrams daily and can titrate up to 100 milligrams daily if needed. During the administration of losartan, it will be important to monitor renal function and serum creatinine levels. These levels should be ordered when initiating therapy, after the first week, monthly for the first 3 months, and then annually. Also when increasing doses. Since this is a new medication for him, education should be focused on administration, storage, adverse reactions, how to respond, as well as necessary lifestyle education. This patient should be monitored for and reported any symptoms related to hyperkalemia, hyponatremia, angioedema, renal impairment, orthostatic hypotension, syncope, dizziness, and insomnia. The medication should be taken as prescribed, and any missed doses should be taken as soon as remembered, unless it is close to the next dose. Do not double dose if missed. Over-the-counter medications, cough or cold drugs, diet pills, stimulants, and NSAIDs should only be taken after consulting a provider first, as they may counteract the medication, causing an increase in blood pressure. Hypotension is an adverse reaction and may cause falls, and the patient should be educated about changing positions slowly. The patient also needs to be educated on the importance of adequate hydration to prevent dehydration, especially in hot weather or when working out, sweat loss, and other conditions that would cause fluid loss, and should report any swelling in the feet and ankles or decreased urine output. The patient is currently on atorvastatin 10 milligrams, and the patient's total cholesterol level is 189. Even though his total cholesterol is within normal range, I would increase the dose of atorvastatin to 40 milligrams, as the patient is considered high risk due to his hypocholesterolemia, hypertension, and TIA history. It is recommended that patients who are able to tolerate statins are treated with 80 milligrams for ischemic stroke prevention. But due to the patient's normal total cholesterol, I would start with 40 milligrams daily. I would continue to monitor the patient's fast lipid levels, initially 3 months and then move to annually, to ensure LDL levels are at the targeted range of under 70. If the patient is not at the targeted range of under 70, I would increase the dose to 80 daily. The patient is currently on aspirin 325 milligrams since his TIA 3 months ago. It is recommended that low-dose aspirin is sustained as prophylaxis during treatment of gout. However, I did find mixed research and opinions on this due to the effects of kidney retention with uric acid. Therefore, I would take the patient off the aspirin, 325 milligrams, and replace it with clopidogrel or Plavix, 75 milligrams, for long-term therapy of ischemic stroke prevention. Clopidogrel has a quick onset and peak, so the patient can stop taking aspirin and start taking clopidogrel without having a lapse in treatment. Since this is a new medication for him, education should be focused on administration, allergic adverse reactions, and how to respond to them, combined with lifestyle education. It will be important that the patient understands that he is at increased risk for bleeding and bruising if he falls, hurts himself, or hits his head in those situations. He should call his and in those situations, he should call his provider. He will need to consult with a provider before using NSAIDs, garlic, blood thinners, ginseng, ginkgo, pain medications, or vitamin E. This medication will need to be discontinued 5 days prior to surgery. It is important to let all healthcare providers know that he is taking this medication. The medication should be taken as prescribed, and any missed doses should be taken as soon as remembered, unless it is close to the next dose. He should not double dose if one is missed, and should not stop taking this medication without consulting his provider. The patient is currently taking flunizolide, 2 sprays in each nostril, and pseudoephedrine, 60 milligrams PRN, for his chronic sinus drainage and rhinosinusitis. I will have him continue taking the flunizolide, but I will inform him that he needs to stop taking the pseudoephedrine. Pseudoephedrine could counteract the losartan, causing the elevation of the patient's blood pressure. I would educate the patient on appropriate antihistamines that he could take, like Benadryl, Claritin, Zyrtec, to help with his rhinosinusitis. I would also want to know more about his rhinosinusitis, what makes his symptoms worse, what medications he has tried in the past, and if he has ever been tested for allergies. If he has not been tested for allergies, I would place a referral to help determine if the patient has allergic rhinosinusitis, AR, or non-allergic rhinosinusitis, NAR, in order to provide an individualized treatment plan. For the treatment of gout, I would prescribe allopurinol with an initial dose of 100 milligrams daily in the AM to be taken with food and water, as it prevents and or lowers high uric acid levels in the blood. Even though colchicine is a first-line treatment of gout, I have decided not to prescribe it due to its drug interaction with the atorvastatin. The dose of allopurinol can be titrated up in increments of 100 milligrams every 2 to 4 weeks until the patient is in the targeted uric acid level of less than 6. The majority of gout patients achieve therapeutic range around 300 milligrams, but every patient is different, and it is the uric acid levels that determine the therapeutic medication range. The patient should not be prescribed over the maximum dose of 800 milligrams daily. It is important to educate the patient on the importance of staying hydrated to help with gout and prevent dehydration. This is a new medication for him. Education for this medication should be focused on medication administration, allergic reactions, skin itching, rash or hives, and how to respond to those allergic reactions, combined with lifestyle changes. Since this patient is a truck driver, I would encourage him to avoid driving until he understands how this medication affects his alertness. Patient education should be on the possible side effects, which include diarrhea, nausea, precipitation of acute gout attacks, and to immediately report any skin rashes. Glucocorticoids is a reasonable alternative to NSAIDs to help with the pain by reducing and preventing inflammation. Even though this patient has a elevated fasting glucose, and glucocorticoids can cause drug-induced hypertension, I feel that the short-term benefit outweighs the risk for this patient. It will be important that the patient monitors his blood pressure at home. For patients that have 1 or 2 joints, intra-articular glucocorticoids like triamcinolone, acetotonide are highly recommended, and patients often have relief within 24 hours. If the provider does not have experience in administering intra-articular injections, this should be avoided. And an oral glucocorticoid like prednisone can be prescribed. The dose for triamcinolone is 1 time 10 milligram intra-articular injection into the affected joint. If there is a possibility of infection, the synovial fluid should be cultured first. The dose for prednisone is 40 milligrams daily until the patient's symptoms subside, then tapering slowly. Steroids are crucial in helping to reduce inflammation, but they also have serious risks, and adverse drug reactions. It is important to prescribe the lowest dose for the shortest amount of time necessary to control the symptoms. Possible adverse drug reactions include acne, crushing syndrome, weight gain, easy bruising, irritability, aggravation, hair growth, increased susceptibility to infections, insomnia, stomach irritation, peptic ulceration, potassium and calcium deficiency, aggravation of pre-existing conditions, diabetes, high blood pressure, glaucoma, and increased cholesterol and triglycerides. It will be important that the patient is educated on taking the drug exactly as prescribed, not continuing the medication without consulting a provider. If oral, eating a diet high in protein, potassium, calcium, and low sodium, incorporating a multivitamin that contains calcium and vitamin D, and to notify a provider for any severe reactions. For this patient, I would initially order additional blood work of HbA1c level, a CBC differential, CMP, including BUN, creatinine, and GFR, and a lipid level panel. I would repeat and order blood work based on recommendations. Typically, blood work is repeated until therapeutic ranges are met, at 3 months and annually. During the gouty attack, physical activity must be restricted, and the patient should be bed rest and non-weight bearing for 24 hours post-attack. During the attack, patients can apply ice packs for 10 to 20 minutes several times a day to help ease pain and reduce the inflammation. Once the acute attack subsides, typically within 24 to 72 hours, heat can be applied for comfort for 20 minutes 2 to 3 times a day. The patient needs to understand that excessive exercising, trauma, dehydration, alcohol, binge eating high purine food can all trigger a gouty attack. It is recommended that the patient's fluid intake should be at least 2,000 ml daily. It is important to educate the patient on the type of foods and drinks that are high in purine, like red meat, organ meat, seafood, which includes mussels, scallops, anchovies, herring, sardines, trout, haddock, mackerel, and tuna. Drinks in high fructose corn syrup, alcohol, especially beer, and vegetables, beans, peas, lentils, oatmeal, spinach, asparagus, cauliflower, and mushrooms. I would also educate the patient on the importance of weight loss. 5 to 10 pounds can significantly decrease blood pressure. Healthy low cholesterol diet, high in fruit and vegetables, low fat dairy, reduction of sodium intake, low carbohydrates, limit purine-rich foods and drinks, limit or eliminate alcohol intake, and increase aerobic physical activity, which are all critical to prevent further complications. I would refer this patient for allergy testing to ensure proper treatment for his chronic sinus drainage rhinitis. Due to the patient's history of alcohol use and poor diet, I would assess if the patient needed resources or support on those lifestyle changes. If he does, I would refer him appropriately. As of right now, I would not refer to this patient to a cardiologist, but if I was unable to control this patient's blood pressure and he was not responding to the treatment plan outlined, then I would consider a cardiologist referral. I would schedule this patient to be seen with 2 to 3 weeks for follow-up. My genius questions. First one. Due to the patient's elevated fasting glucose and family history of type 2 diabetes, would you consider another medication or treatment for his chronic sinus drainage rhinitis? Would you feel comfortable prescribing both flunizolide and glucocorticoid? Question number 2. There are mixed reviews and studies about patients taking aspirin when they are diagnosed with gout. Would you keep this patient on aspirin? If yes, then why? And what dosage? And if no, then why not? Question number 3. What is an alternative medication that can be prescribed to treat gout for this patient? Does it have any drug interactions with his current medications? What would be the benefit of this drug?